Adolph, how are you?
Hey, Michael, how you doing, man? Good to see you. You looking good?
Good to see
Healthy?
you. Oh, thank you. Oh, that's great. I love your background. That's fantastic. So welcome. You're at the board meeting of the Healthy California Now campaign. It's a coalition of organizations devoted to winning single payer in California. It's been active. Many of the folks here have been active in this effort for many years. And we're now dealing with a commission that's studying the single payer financing and other approaches to universal healthcare unified financing. So it's in that context that we meet currently. Historically, we've supported state-based single payer legislation, as well as working on national Medicare for all. And we'll be joined by Dr. Dooley, who is a private physician and a surrogate for the Bernie campaign. She's finishing up with a patient. So we're going to start with you, then Dr. Dooley, and have a discussion.
Okay.
Let me just quickly introduce you. Adolph Reed is, I think, now retired as an American Professor of Political Science at the University of Pennsylvania, where he specialized in race and American politics. He's taught at Yale, Northwestern, and New School for Social Research, written extensively on racial and economic inequality. You all got an article by him in the New England Journal of Medicine on racial disparities in healthcare and how to look at that from a structural point of view. And in terms of economic inequality, he is a contributing editor to the New Republic and has been a frequent contributor to the progressive magazine, The Nation, and other left-wing publications. He was a founding member of the U.S. Labor Party and is engaged as an advisor to the president of the State Federation of Labor in South Carolina, where he's been doing work to win Medicare for all and to build support among the constituents of James Clyburn, member of Congress, and others for Medicare for all in South Carolina. So Adolph, thank you so much for joining us.
Oh, hey, well, thanks for having me. And by the way, that's a big chunk of our South Carolina team in the background there. So I guess, I don't know, I was trying to figure out what's the best way to use the 10 minutes, and I'm going to try to stick to the 10 minutes. And I was thinking maybe the thing to do is to talk about how to think about what racial disparities mean as a political concern at this moment. It seems like it's an especially fraught and important and dicey question now. And with respect to COVID-19 in particular, I guess that's a way to start. Also in thinking about the struggle for Medicare for all across the board. On one level, the fact that there are substantial disparities that show up in health outcomes by race isn't really surprising. It's kind of what you knew going in, because there are patterned inequalities that overlap race, that race is something of a marker for. I should back off that. But at least it overlap race, right? So when you find that Blacks and Latinos have it worse, whatever the worse is to have, that shouldn't be surprising. But one of the things that I've been curious about for a long time, and my co-author in the New England Journal piece, and he's a public health professor, a number of years ago, we actually did an article examining what we called racial disparitarianism. And one of the concerns was, what is it that people, why is it that people think they found something earth-shaking when they found the racial disparity, when the racial disparities in the distribution of good things and bad things would be what you expect in the first place? And I don't have an answer for that, but I think it's something for all of us to kind of think through together, right, as we go forward, because when you get down to it, right, I mean, the first, the standard punchline is that the existence of disparities show that racism is a force. Well, no one really doubts that racism is a force, right? And I'm concerned that often the problem with that rhetorical pattern is that adducing racism functions as an alternative to an explanation, right? So if we take the case of elevated morbidity rates from COVID-19, as I said at the outset, I mean, we can assume that if bad things are going to happen with the spread of a contagion, then the poorest, the most vulnerable, the people with the most compromised access to healthcare, et cetera, et cetera, et cetera, are going to suffer, I mean, disproportionately. People who are more likely by dint of the political economy of neoliberal capitalism at the current moment, anyway, the proximate source, people who are more likely to work in frontline jobs that would expose them, people who are more likely to work in casual jobs who would expose them, people who are more likely to live in housing conditions that would make them more vulnerable. Putting all those causal factors together under a label racism doesn't do very much for us politically. It doesn't do very much for us ideologically. It doesn't do very much for us in terms of thinking about how to respond to the nature of or to the problem and to improve people's lives and conditions. So, I mean, it might sound like a little off the wall as a way to go, I mean, today, but what I would suggest is that it would be useful for all of us as we go forward to think about what people actually mean when they say that, aha, racism is the cause of inequality. So I think I'll stop right there for a second, or just stop right there. I guess that's kind of close to my time anyway.
Well, Victoria is still, I think, or Dr. Dooley is still finishing up with her patient, yeah. So we probably have a few more minutes.
Michael, but take your time, but I'm here.
Oh, good. Oh, you should go then.
Okay,
oh, fantastic. Great. All right. All right, fantastic. Well, let me just do a brief introduction. Dr. Victoria Dooley was someone I had the pleasure of working with during the Bernie 2020 campaign. It was one of the most dynamic and exciting and popular surrogates for the senator on Medicare for All. She is a family medicine expert physician practicing in Novi, Michigan, and has done extensive media work, and also is perhaps known particularly for her dynamic Twitter and her following there. So we circulated the policy she developed on reproductive justice and Black maternal health. And so really grateful that you could join us today, Doc. Thank you so much. Great to see you. All right, you may be muted.
Can you hear me now?
Yes.
Okay, excellent. So why is Medicare for All important for all people of color? Well, there's several reasons. And a lot of the pushback that I got, which was really nonsensical to me when I was a surrogate for Medicare for All, often from people of color, was Medicare for All isn't going to cure racism, right? And to me, that was kind of a silly statement, because when you look at the progress that people of color have made in this country, eliminating slavery didn't cure racism, right? But it improved our lives. So just simply saying that something is not going to eliminate racism, therefore is not good, to me is a kind of a nonsensical thinking. So with every effort that we've made in this nation, whether it be through Medicaid expansion or the Affordable Care Act, every single time, there's still a disproportionate amount of poor people of all colors, but mainly Black people, brown people, who are still left uninsured. And I personally do not believe that that's a coincidence, because it wouldn't take a rocket scientist to figure out how can we make sure that all poor people, all people of color have insurance. And that solution would be to guarantee healthcare for everyone, like they do in every other developed nation in this country. And when you look at Black women specifically, Black women over the age of 19, 50% of Black women over the age of 19 have some form of heart disease, whether it be from high blood pressure or whatever. 50%, 1 out of 2. And before I started practicing, if I would look at this statistic, I wouldn't really believe it, because I'm fortunate where I come from a family with some good genetics that me, my mom, my sister, we don't have heart disease. But then when I started practicing it and all these lovely Black women started coming to me, and I'm like, wow, I saw it. 50% of Black women really do have some form of heart disease. And so these women are young, a lot of them, 50% of women over 19 have heart disease. So we need to start caring for them before they get pregnant. So you can't have somebody who cannot afford to go to the doctor and get their blood pressure controlled. And then all of a sudden they're pregnant and they have all these complications, right? Because their blood pressure has been uncontrolled for years and years and years. So providing a Medicare for all system is important to give all women, but especially women of color, the care that they need to address their diabetes, to address their high blood pressure before they get pregnant. It's a proactive versus a reactive approach. And when you think of some of the solutions that some people have thrown out there, let's take, for example, some people have suggested, well, hospitals who have high rates for Black maternal mortality, we should decrease funding to them. And that's such a flawed logic, because when you look at the data, the majority of Black women deliver at a concentrated set, a small percentage of hospitals. And the hospitals that they deliver at are hospitals that accept a large percentage of Medicaid patients. Medicaid pays less than Medicare. So most women of color are delivering at hospitals that are underfunded. So you're telling hospitals that don't have the resources to implement evidence-based guidelines, something as simple as, hey, let's come up with a protocol so that when women start hemorrhaging after they deliver, let's come up with a protocol and train everybody on it and research it. They don't have the money for that. So you're going to tell these hospitals that are underfunded, we're going to take even more money away from you. Whereas we need a system where we can have a capital budget and we can get these institutions the finances and the resources that they need, as opposed to taking away resources that they already don't have. These institutions aren't killing Black women simply for the fun of it. They don't have the resources and the knowledge and the finances to protect them. And as a healthcare provider, I'm very passionate about all my patients, but especially my patients of color, and I'm very hands-on. And we have to believe Black women. We need a BBW campaign, believe Black women. But when you say something like that to providers, hey, let's believe all Black women, some are going to be in denial. They think they're, because they're not consciously discriminating against women of color. And so we're going to say, look, let's have a system where we can believe and treat Black women the same as any other woman. But when you look at the way we have these tiered system of insurance here in the United States, it's impossible, because with Medicaid, there are certain medications that I cannot write for my patients because they're not going to be covered. There are certain specialists that I might want my patients to see, but they're not going to accept Medicaid because it pays pennies on the dollar. So as healthcare providers, our whole entire system is based on judging people. And people who have Medicaid, they have this scarlet M on their chest, and it tells everybody they're poor. Nobody should know your household income based off some letters on your insurance card. That is unacceptable. So when we say, look, everybody's going to have the same insurance. And if I need to get you to a specialist, I know if they accept insurance, they're going to accept your insurance, because we've transitioned that all private insurance is a Medicare for all system. I think that's crucial to getting healthcare providers on board, to understanding we have to treat all human beings as human beings and not have to worry about finances. Because when patients have Medicaid, oftentimes their care does suffer because their options are limited. So even expanding Medicaid, if that's going to be the best that they're going to give us right now, we have to live with it. But for advocates to say the best that women of color can do to expect to decrease the Black maternity mortality is to expand Medicaid, to me, that's such a flawed and insufficient solution that we must address by saying, all humans are equal, and getting that in providers' heads, that we don't have to judge people based off of what their insurance company is going to pay me. That's crucial to ending the disparities. So I hope that was helpful.
All right. Thank you very much. Indeed it was. Indeed it was. We're going to have some Q&A from the board. I want to ask a couple questions to begin with. I want to start, Adolph, just elaborate a little bit more on your analysis in the New England Journal of Medicine article where you talk about really that we have to identify the socioeconomic factors that play out. And it's really kind of along the lines of what Dr. Dooley is saying, is that these have expressions that look, and they are disproportionately impactful of Black women. Those, though the source of those disparities often are in the socioeconomic status, the type of insurance they have, the type of jobs, the fact that we see in California that this new uprising in coronavirus cases is among Latino workers who are having to go back to work in essential jobs where they're exposed to large numbers of the public. And it derives directly from the fact of their economic circumstance. So can you talk a little bit about what these key socioeconomic factors are, as opposed to kind of a racialized biological explanation?
Well, yeah, sure. I mean, I think the key point is that the racial shorthand can leave open the possibility for people reading in biological arguments, or I mean, biologistic arguments, right? Because there's no foundation for them in actual biology. And if we're not clear that race, and look, I mean, I think a part of the issue is that the way that public health data are collected in the US is such that the data aren't collected by income. So race or ethnicity, which is just a polite way of saying race, right? It's like race dressed up as culture, basically, function as proxies for class and income. And many researchers understand it that way. They treat it that way, but it's not a very good proxy, obviously. But so one problem is, there's enough sort of cloudy and fuzzy-headed thinking out there about what race is and what it isn't. It seems like it ought to be the most, banal thing in the world to say that there are no sub-specific naturally occurring populations within our species between like the localized breeding group and the species. So as I would often say to students, when someone says race, you ought to think unicorn, because it's the same kind of taxonomizing exercise, and especially in biological terms. But I'm sure that most of the board, I mean, a lot of us know, the horrible history of mischief, right, and worse than mischief, right, like the train lines that end at Auschwitz, right, that have been grounded on the premise that there are fundamentally biological differences among these fictive populations called races. So that's one problem. And to the extent that, as I said earlier, that that racism is like the easy shorthand for the socioeconomic conditions. I mean, you're right, like a lot of them Dr. Dooley already mentioned, I think I mentioned a few earlier too, but like the kinds of jobs that people work, right? The kind of access to healthcare that they have, the kind of access or the conditions of like everyday stress. I mean, I'm sure everybody knows that, being chronically broke is like stressful and it hurts the body, right? And sort of housing conditions that people have, right? The toxicities that people are exposed to in their work environments and in their home environments. And nursing home care, right? I mean, it was fascinating, and especially being down here right after Louisiana was defined as ground zero for a couple of minutes till it wasn't. But I realized that half of the deaths in the first couple of weeks in Orleans Parish were in one upscale nursing home, right? And included a former NFL place kicker, but that's another story. So it's the social conditions that people experience, and the social conditions, again, I don't want to be an ideologue about this, but that are attendant to capitalism, and especially to neoliberal capitalism. That's been from the beginning all about shredding whatever safety nets we've been able to fight for and win over the last 70, 80, 90 years. And I think we're at a point now, right? Like when we think about stuff like, you know, the question of how to pay, right, for Medicare for all, and what a just transition is actually going to look like, then that sort of opens to other, considerations like the need to reorient public policy across the board from right onto the standpoint of a focus on the public good, and that sort of connects with ways to talk about the Green New Deal and whatever else. But the tendency to moralize, right, about racial disparity, right, and it's almost like, right, a kind of a knee-jerk thing. Like when I was a little kid in Catholic school, they trained us to write Jesus, Mary, Joseph on the top of our papers, and there's a way when people say blacks have it worse, right, like it's like that, right? It's not even something that you think through, right? It's just a reflex, right? And we've got a hell of a fight coming, and we've been in it, and it's only going to get worse. And I'm not saying anything new to anybody on your board, but I think it's imperative that we sort of think strategically and as clearly as possible about how to get ready for it. I mean, I don't know. It feels a little bit like you asked me what time it is, and I told you how to make a watch. So I'm sorry if that's the case.
Not at all. Not at all. I think, Dr. Dooley, that there's a lot of continuity there in terms of your analysis. When you developed the policy on Black maternal health, you were very clear to address things like reproductive justice, real access to reproductive services, to dealing with the stress that the higher levels of toxic stress that women of color experience. And very clear about addressing the social determinants of health. So what do you think, a Medicare for all system that addresses these questions looks like, in the sense that you describe it as, culturally competent care that really is led by community organizations that treat the communities of color? I think you're muted again. Doc.
Sorry.
Yeah.
Numerous things, Michael. When you think about health and social determinants of health, of course, in order to get the prenatal care a woman needs, she has to have access to the doctor, a means to pay, a way to get there. So I believe if we have a universal system, single payer system, then we as physicians, we should be able to write prescriptions for transportation or Uber vouchers for women who need transportations to get to their appointments. I mean, this is part of their health, so it should be covered. And that's going to be more easily accomplished with having a single payer Medicare for all system. When you think about this pandemic, and people weren't coming into the doctor anymore, and Medicare was very clear about changing their policies to cover telemedicine, okay? So Medicare in its existing form has flaws, but they were really good about that. They're like, boom, we're gonna cover it. It was clear. It was a website, it was clear as day. But with all these private health insurance companies, when we switched to telemedicine in March or April because of the pandemic, as physicians, we didn't know if we were gonna get paid. And I remember there was a day I sat on the phone on hold, put it down. We sat on the phone on hold for an hour trying to find out with one of the major insurance companies where they're going to pay for telemedicine, number one. Number two, was a reimbursement going to be the same because we need to pay our bills and pay our staff. And after sitting on the phone for an hour, they basically said something, and they said, but things are changing rapidly, so call us back tomorrow because it might be different tomorrow. And I'm like, we waited on the phone an hour to talk to you, and we're supposed to call you back every day. So as physicians, in order to take care of our patients, would be better able to advocate with one health insurance company for things like transportation vouchers. If I need to write a patient a prescription for formula, we need to either expand WIC, or doctors need to be able to write a prescription for formula for low-income families. Black women are more likely to have infants, twice as likely to have infants die within their first year of birth. And there's numerous factors that contribute to that. And then finally, we need more Black health professionals. So Medicare for All in itself is not going to do that, but hopefully with this Medicare for All system will make us realize is that yes, we need more health care providers, period, but we especially need more providers of color. And evidence shows that usually patients of color usually have better outcomes when their healthcare providers look like them. So if we have this universal healthcare system where everybody's uninsured, I hope that the next step as a nation would be to realize, hey, we need more doctors. We need more doctors of color. It shouldn't cost $350,000 for somebody like me to achieve their dream of being a primary care physician. And so the next thing that we'll transition into is making education affordable for healthcare providers who have to carry this huge burden of hundreds of thousands of dollars of debt. So Medicare for All, I hope, is going to set off this cascade effect of realizing that we really need to advance from this reactive to a proactive in developing a system that we can use to address all social determinants of health.
Because it really looks like the healthcare infrastructure that Black people depend on, in particular, the public hospitals, the community clinics, the social service programs like WIC or other programs, those are the ones that are most severely underfunded because all the resources is going to the for-profit model. So essentially, it's a reorientation of the resources to public health institutions, to community health institutions, where folks are going to get who go, that's where they already go to care, but as you say, lack the resources to actually make it effective to meet their needs. So we're really talking about when we talk about different financing, single payer financing, we're talking about reallocation. So it is part, and it could be part, would necessarily be a part of shifting resources, say from police to healthcare, from other, essentially, right, care not cops, as we say, right?
Yeah.
So, Eric, I want to give Sal a chance for the board to weigh in here. And I don't know, Sal, if you had any question in particular, if you wanted to start us off. Sal Roselli is the president of National Union of Healthcare Workers, key sponsor of our Healthy California Now coalition, and a longtime advocate and just one of the really one of the my heroes and one of the great labor leaders in California. So Sal?
No, I just want to thank you for your time being here and welcome you. And this is like day one of a new endeavor that I think we're embarking upon. So your leadership is much appreciated. Certainly going to be sharing it with our staff and our members. Thank you again.
Hey Sal, how you doing, brother? How you been?
Very good. Good to see you.
Yeah, likewise.
May I ask a question?
Yes.
Yeah. Hi, thank you both. I guess this might be more for Dr. Reed. I appreciate all of your comments, and made me think about, the need for building alliances with low-income white people in this movement, among communities of color and low-income working class white people who are really in the same circumstances. Like when you say it's racism, well, there's also a lot of white people affected by the same stuff. So it strikes me as a great opportunity on this issue in particular. I mean, that's kind of true across the board, but are you familiar with, efforts or organizations or strategies that have been able to do that effectively?
Well,
first of all, I assume you would agree with what I'm saying. If you don't, tell me.
Yeah,
but
well, because I can count, right?
Yeah.
But yeah, I mean, well, I tell you, like we've been focusing in South Carolina, and it's been kind of hard since we haven't been able to get down there and get around a lot. But before we went on lockdown, we had a really instructive session with I think 6 presidents of locals in the communications workers union in the upstate around Greenville, Spartanburg. 4 in the room and two by a remote hookup. And we learned that before the meeting that a couple of these presidents had voted for Trump. So we're waiting for it. And what we came away from that meeting with, and this is like just one facet of a response to the question as you asked, which is a really important one. But we found just, like in organizational terms, right, that meeting with the local presidents without their members was good because it made them feel free to ask questions about what Medicare for All was, how it would be paid for, how we could fight for it. Like the death panel thing even came up, and one guy was ventriloquizing his members, right? He was saying, asking about the death panels. And like, these are questions that you can best deal with in like smaller settings that are more direct and more intimate, and that is performative as a big training session, right? But the other thing that we found, that of the 2 Trump voters, one of them, they both were okay and good trade unionists, but one of them was like the most politically sophisticated, pissed off, and astute of the lot. And it's a reminder that, there is, right, no matter what people think in the New Brooklyn, there is a distinction between people who voted for Trump and people who are Trump supporters, right? A lot of people voted for Trump because they couldn't stand Clinton, and they couldn't stand Clinton for good reasons and for bad reasons, right? But one of my favorite data from the 2016 election, what was it, somewhere between 6.7 million and over 9 million people who voted for Trump had voted for Sanders in the primary and Obama for president at least once. So that tells you that there's something else going on there besides working class white racism, right? And I just think that you talk to everybody basically the same way, right? Because, working people have the same problems. And I guess another thing that we found that's a little off the point of your question in South Carolina was that, there's a kind of organizing 101 thing about how you've got to have people tell stories and give testimony. And that was totally unnecessarily or unnecessary for us, because we were working with what was basically a working class population. So people knew they didn't need to hear the horror stories about the for-profit healthcare system, because they lived the horror stories from the for-profit healthcare system. So I guess, like, in sum, I would say, we can't win this without winning support in the broad working class. That's a constituency that, to whatever extent we are able, we've got to take back from Trump to whatever extent he has it in the first place. And it just seems to me that a focus on solidaristic questions, and this is why the labor movement, like, is so important. I gave a talk at a steelworkers local, like in Georgetown, South Carolina, and one white guy said, well, I like Sanders' economic program, but I don't understand why the Democrats just get bogged down in what he called the moral issues, by which I assume he meant, same-sex marriage, abortion, right? Whatever. So we talked about it, went around about it for a while, and where we finally got to was my saying to him, well, look, what's more important to you ultimately, right? That 2 people of the same sex can never get married, or that you don't have to worry about having access to healthcare. And we went on about that, right, around some other issues. And I'm not saying I won him over. I'm not that good, but I think that somebody who has standing with him in his personal life and personal networks could win him over, at least to the extent that he might not like it. He might not approve of same-sex marriage, or he might think that abortion is killing a baby, right, or whatever. But we've got to hope that there's enough of the population who, if given the opportunity to rally to a politics that addresses their immediate and direct concerns in their lives, that enough of them will do it to give us the winning alliance that we need. Sorry, I feel like I'm speechifying. Excuse me.
That's
Could I
great.
just add something real quick?
Doc, yeah, do you want to weigh in? Yeah.
I disagree with everything that Adolph said about how, you know, people are living these stories. That the Republicans can pretend that that there's all these people who love their health insurance all they want to, but it's just not true. And so as a Bernie Sanders surrogate, when I was talking to people and I didn't know where they were, I didn't throw out Bernie Sanders. And even with healthcare, I typically didn't throw out, unless I knew the audience I was going with, Medicare for all. I'd just be like, hey, you know, wouldn't it be great if you could just go to the doctor and not have to whip out your wallet? I mean, who's gonna disagree with that? Wouldn't it be nice if you could just go to whatever hospital you want and not have to worry about what network it's in? And then, yeah, that would be great. Wouldn't it be nice if your kids were able to go to public school and you not have to save up for it, public college, just like they're able to go to public elementary and you not have to save up for it? And so you get people saying, yeah, that would be a great thing. And then I started to talk about, well, did you know that, you know, Senator Bernie Sanders has this program called Medicare for All that does exactly that. So what we're talking about as far as providing health care, that's going to be no out-of-pocket costs, that's going to be able to let you go to any doctor, hospital that you want and have no fear of medical bankruptcy and no fear of financial ruin. Everybody wants that. But how you approach it can, you know, they just will shut you off completely. If I just would have been like, hey, you know, let's talk about Bernie Sanders. No. But when I just say, hey, you know, let's talk about these general healthcare frustrations that all people of all color have, then they're more apt to get on board. And I think with rural communities, specifically, I saw some rural communities in South Carolina, and just thinking about how we saw the small local hospital that was closed and how pregnant women were having to drive an hour to get to the hospital when they had delivered. And this was your second or third baby, you don't have time to make it to the hospital. So if I was approaching a rural community, I would talk about, you know, a system where hospitals aren't going to be closed because they're not profitable. We're going to have one budget. We're going to make sure everybody has the hospital that they need. I'm going to talk about a system where, as part of your healthcare benefits, you can get a transportation voucher so that you can get to your appointments that you need. So we all have the same needs. It just is a matter of how we initiate the conversation. Is somebody going to instantly tune us off, or are they going to be willing to listen?
Other questions for our panelists?
First of all, thank you. I froze and then bounced off for a bit, so I missed some of what you said, but I appreciate everything I heard.
I thought you froze.
Paul, go ahead.
Yeah, let me get, now I'm unmuted. So I retired about 4 years ago, after 30 years in primary care, almost all in rural areas as a nurse practitioner. And I really hear what Dr. Dooley is saying about clinicians. We need more clinicians, and obviously a single payer insurance system that with capital funding and global budgets for institutions and particularly hospitals would help that, as would loan forgiveness. And you know, I started my nursing career back in 1975 directly as a result of the CETA program. And part of the CETA program was that in return for my nursing education, I would work in an at-need community. And those kind of trade-offs are tremendously effective for both communities and for clinicians, and a real learning experience. So much of what I heard from both Dr. Reed and Dr. Dooley today, I think is really on the mark. I guess most of the questions that I had you answered in the way that you gave your presentations. And I definitely applaud what you're saying, Dr. Dooley, about how you bring the conversation up. Not let's talk about Bernie Sanders, but let's talk about how we all really would be happy if we didn't have such a hassle getting health care. But so my question, I guess, would be all the way around in all of the identity groups that we have now, who many times what motivates them is, like you say, when I see somebody who looks like me, I may be more likely to do what they say or to listen to what they say. How in that context that we're living in right now, do we move this forward?
Well,
Doc, you want to take that first?
yeah, I mean, that's a good question. To be honest, I'm not so sure that I accept the premise, right? I mean, yeah, it can help, right, as an icebreaker. But in my experience, people will respond to people who will struggle with them for the things that they're trying to struggle for. And it doesn't make that much difference what you look like. Now that's, I mean, that's something a little different from, you know, how kids react to teachers or how healthcare practitioners can put a patient at ease. But I just don't think there's got to be a one-to-one correspondence, right? Like if I can't just, or I don't just go to a Catholic doctor, you know what I mean? Right, because we belong to the same parish or whatever. I mean, I don't go anyway, but I mean, yes, it can help, but I don't think that we have to sort of bend ourselves up into pretzels to go, you know, send a Latino person, except for the language concern, I mean, to organize a shop that's like 40%, I mean, Latino, right? I mean, it's something to be mindful of, but I just don't think there's a rule of thumb that's sort of necessary there. But I don't know.
Well, this might not answer your question exactly, but what I do in the office is, like I said, I'm really possessive of my patients and I advocate for them. So I've had patients who I felt weren't listened to by a specialist.
Mm-hmm.
And so I will call them up and I'll say, you know, it might be somebody who's super high risk for prostate cancer is going to be an overweight African-American male. And so if I think they are at high risk for prostate cancer and I send them to the urologist and they don't do a complete workup, I'll get on the phone and I'll call them. And I'll just say, you know, hey, how you doing? Thank you for taking care of such and such. You know, as an obese African-American male, you know, he's at highest risk of dying for prostate cancer. And I don't think that he quite understood the conversation that you had with him regarding his risk. So I kind of, you know, I talk to them in a way that makes them think, maybe I did miss something without accusing them. And so I've developed these relationships with healthcare providers that don't look like me to the point where I had to, because I have to have somewhere to send my patients. And because there's not a lot of doctors of color, I can't send all my patients to doctors of color. So I would talk to them not in an accusatory way. And so I've kind of got this reputation now that I like to know what's going on with my patients because I'm going to be checking in with you. I don't admit to the hospital, but the ER knows when patients come to the emergency department, I like for somebody to give me a message or leave me a phone call because I've had patients call me from the hospital, like Dr. Dooley, and I'm like, I didn't even know you're in the hospital. So what I do as part of my practice is to remind some of these providers who may not look like me how much more of a risk patients who look like me are, because they might not be thinking of it consciously, or I don't know why, it doesn't matter, but I have to politely remind them, like, look, this is a high-risk person. Are you sure we're not missing anything here? And cultivate those relationships so that they know when they take care of my patients, especially my patients that look like me, that they have to be addressing them for their specific risk factors because of the systemic racism that puts us at higher risk for so many illnesses, that when they see my patients of color, they need to think about it because I've reminded them respectfully.
Yeah, I think those two perspectives are not in conflict. I think that providing culturally competent care, right, in a way that's actually going to meet the needs of a diverse patient population is what a universal healthcare system has to do. And to achieve that universal healthcare system, we're going to have to talk to people with where they're at and be able to really, as you both have described, get to their experiences in a way that maybe doesn't get bogged down in assumptions or labels like Medicare for all or what ideological position you're coming from, but the reality of what people actually experience in healthcare. And it seems like, Adolph, in your case in particular, working with labor is really crucial, although there's some irony in South Carolina because it's like the least, I think, union dense state in the country. But can you talk a little bit about the importance of labor in that organizing? Because I think that is a pretty significant aspect of what's going on there.
Oh, absolutely. And I mean, we've been, and look, in all fairness to South Carolina, they go back and forth with North Carolina for having the lowest union density almost every other week. but it's like 2.6 versus 2.4. Well, see, it's kind of a funny thing. I mean, and one of the things that we found, like through the Labor Party experience and this other work, is that it's often tougher to broach the message about an unconventional way of thinking about politics in places where the labor movement is nominally strong, right? Because there's always this sense that, well, my Democrats can take care of us, basically, right? And which is good when you have it, right? In South Carolina, for instance, I mean, Donna DeWitt, when she was president of the state Fed more than 20 years ago, reached out to the Labor Party, which is how the relationship began, because she knew that they weren't getting anything from the Democrats and they weren't getting anything from the Republicans either. And we started to work down there with her and with the longshoremen from the ILA local. I think you know that we won a ballot line for a South Carolina Labor Party. And Charles Brave from the ILA, who was the new president of the state Fed, is somebody who's an old friend who we've worked with for more than 20 years at this point around a number of issues. And the way that, and again, like this is one of the things that's so frustrating about being on a lockdown, that we've been trying to put together an organizing approach to the affiliates in the state Fed, because that's what was kind of like, even in a state where the union density is so low, right? It's almost like you can use the community organizing to get to the unions, right? But it's low compared to what, right? Like to what else you got, right? Like to 45 kids with tattoos running around the street. I mean, or the church basement people, whatever. So it's a base, right? And it's like the famous bank robber Willie Morris once said when he was asked why he robbed banks, he said, because that's where the money is. And the unions are where working people are going to be organized politically as a class to the extent that they're organized politically as a class anywhere. And I mean, like my conversation with the guy at the steelworkers look, I said to him too, I said, look, I'm sure there's some guy on your shift at the paper mill whom you hate. Like you can't wait to punch out so that you don't have to look at him again until you punch in next time. But I also bet you that on union matters, right, you and that guy, even if you hate each other's guts, can find a way to work together on the work that has to get done. And that's something else that experience in the labor movement brings, right? So it like brings you organizers and a way of, and just a general approach, right? To doing a kind of politics. Like ironically, people often don't seem to take the trade union way of thinking about politics in the workplace to their electoral political actions, right? So they often tend to want to do it on the cheap or whatever. But I don't know if that's helpful or on point at all.
I think it is. It is. Eric, I think you had a question.
Yes, thank you, Michael. Thank you so much, Drs. Reed and Dooley. I really appreciate both of you being here. We have a chance, I believe, and this coalition believes, in California to enact single payer through what is known as the Healthy California for All Commission. It's a body formed by the governor and the state legislature, and we have some single payer allies on the commission. I guess my thoughts are on this topic of like raising class consciousness and how do you address Medicare for all with your community or with your patients. How might you adapt that to a legislative body, how do you bring these topics of racial equity in healthcare and why single payer is the way to go to more of a sort of like a dry commission setting rather than like a one-on-one type of traditional organizing situation? How would you address that to a body that has the power to decide to move forward on single payer?
Well, boy, that's a good one. I mean, the first thing I do is like check the campaign contribution history, right? So like we spent a minute thinking that we might be able to sway Jim Clyburn on the Medicare for all, and then we looked and saw that he'd gotten $1 million from in 10 years from the pharmaceutical industry. So I mean, so that's one consideration. I mean, well, you know how it goes. I mean, well, I think you guys are all a lot better at doing this kind of stuff than I am, and I suspect that you know, Dr. Dooley's even better. Well, not even, but is also better doing it than I am. But I mean, you make the case, right? But you make the case based on need. You make the case based on cost and irrationality. But then at the end of the day, it's like, I mean, like when I've done electoral work, and granted, this is partly reflects that I lived for most of the 90s in Chicago, but I often prefer to deal with the hacks than with the reformers, because with the hacks, it's like a simple transactional proposition, right? Right? They want to know what you want, and they want to know what you can do for them and what you can do to them. But with the reformers, they get this sort of constipated look on their faces, and this sort of rights in conflict, and yeah, I don't know, like I'm with you, what can we do? Right? And how much do you? So I mean, let me think about it. So it's partly like, so at the end of the day, and God knows that, I mean, you guys in California, in the labor movement in particular, have shown this over the years much more effectively than anybody else. It's like the heat that you can put on them, right? And I mean, I think that they're all, I think every office holder or aspirant is, at the end of the day, just a hologram created by the political forces that they feel obligated to. And I think that's kind of a way to approach it.
Yeah, I agree. Well, now there's a ton of evidence that explains how a single payer system saves money. We are paying for people who are uninsured now. That's why our premiums are so high. So there's a lot of good evidence to point to. And then in this day and age, when you're seeing progressive people win their Senate races, you just need to be honest. Our organization is going to be having seminars and talks in your community. We're going to be knocking on doors, and we're going to be explaining what this is and how it saves money and how it's going to be better for them. And they're going to demand that you support it. Or, you know, we have some people who are going to challenge you for your seat and put you out. And when you look at people like AOC and Booker, even though he didn't win, I think now some of the politicians are beginning to realize that it's not always about who has the most money anymore. That when you meet people where they are, when you go out and you knock on doors, when you get really involved with the community, but not only that, when you're advocating for things that are going to benefit the community as a whole, that they will rise up and start to vote against you.
Right on. Well, we're getting a little close to the end of the hour. Jenny, you want to go ahead?
Hi, thank you so much for joining us, Dr. Reed, Dr. Dooley, and pushing this conversation. I don't know if I'm going to ask this question well. I don't know if it's fully formulated, but I guess I'm just thinking about the things that were mentioned. And Dr. Reed, you mentioned like maybe it's not necessary to send representatives that look like the constituents we're looking for to be involved in the movement. And Michael, you mentioned, you know, meeting people where they're at and respecting the different experiences within the healthcare system and, you know, that different types of people experience. And I guess I'm always thinking about like why we don't have more people of color, you know, Black voices in this movement. And I feel strongly that, you know, there is a class struggle, yes, that whether you're white, brown, or Black, Asian, whatever, like that we all experience, but we're not acknowledging the specific Black struggle enough. And I don't know how you feel about that in healthcare. and how legitimate that is when we fight for Medicare for all. But if we're going to meet people where they're at, I feel like that needs to be a big conversation to really acknowledge the racism in our system, even if that's not part of the policy in single payer or something, like we're not educating on in single payer, but I feel like it's important to have that conversation. Am I off on this? Because we're not talking about it, and that's why I think people aren't part of this movement. You know, I think that is part of meeting people where they're at, because it's not just class, is it? Like, we have to say there's racism in this, because you can have two people of different colors experiencing something totally different or with different consequences based on color. And maybe I don't know enough of the theory. I don't know. I would like to hear what you have to say.
You're absolutely right. Thank you for bringing this up. I believe there are people advocating for it, but you're right, there's not enough. A frustration for me as a Senator Sanders advocate was that there were not enough Black doctors who were willing to speak up. Not enough. I'm not saying that there weren't any, but there was not enough. Even something like the Physicians for a National Health Program, who are a group of physicians who support a single payer Medicare for all system, which is going to disproportionately benefit people of color, because people of color are the ones that are disproportionately uninsured. So going to that convention and seeing the lack of Black and brown faces. And then there's a National Association of Black Doctors, I forget what it's called, but just joining them and seeing how they hint at, we believe that everyone should have health insurance, but not just flat out coming and supporting the only Medicare for all candidate was very frustrating. But when you look at these organizations and things nowadays, a lot of them are just in it for the money, and you got to look at who's donating them and they're sponsoring, and their hearts are not really in the right place. And then when you look at systemic and institutional racism, I have my own practice today, Jenny. And the reason why I do is because the amount of racism I experienced in medical school and in residency as a Black doctor, I just couldn't deal with it anymore. I couldn't go into an office where, you know, I'm not saying a doctor is so high and mighty, but there's certain basic level of respect as any professional in any career should have. And to go into work as a Black female doctor and not getting the bare minimum amount of respect and lies being told, I mean, just I knew I could not go work for somebody, because if somebody did some of the things that happened to me as a resident and a medical student, I would go off, okay? Because I was done. My training was over. I wasn't scared I wasn't going to be able to complete my training. I would just go off, and it would be bad for me because I would have some negative consequences. So I have a lot more freedom than some of my colleagues who work for institutions, private hospitals, and might be legitimately scared that if they speak up, that they're going to lose their jobs because, you know, hospitals the way they are now, you have all these administrators who are making tons of money, and Medicare pays a little bit less in certain insurances, even though it all evens out because some insurances pay less and some pay more. Just health systems in general, the private health systems, they're not on board with us. So I understand the fear of losing your job. That should be a significant fear, right? Whereas for me, you know, I don't have anybody to be accountable to but myself, basically. So I think that's part of the reason. But I agree, it's very frustrating that I did not see more Black doctors saying the sorts of things that I was saying. And I don't know why, but this thing keeps coming up to me, like Medicare for all is not going to cure racism. Like, so many people of color would say this to me, and I would politely try to educate them and make them understand how, in my mind, ludicrous what they're saying is. Like I said, what if somebody said freeing the slaves isn't going to cure racism? Let's not do it. Our goal is not about curing racism. That's going to be a goal that we can never achieve, but we can do better. We can make sure people don't go bankrupt because they're uninsured. We can achieve those things, which will overall help us. So I think a lot of healthcare providers are more fearful of being as vocal as me because of fear of retribution or losing their job. I even had a couple of them online send me a message on Twitter. I really appreciate what you're doing, how you're speaking up. They weren't speaking up, but they would privately message me, not publicly, but privately message me and thank me for some of the things I was saying. So that's absolutely something that we have to address, that which is hard because we have the money interest against us. These big private hospitals, they don't want a single payer healthcare system, but they are buying up practices and employing doctors and taking care of our freedom. So when I am talking to healthcare providers and doctors, I try to talk to them and approach to it. Don't you want your freedom back? Don't you just want to be able to go to your office and take care of your patients and write a script or a test and know without a doubt that it's going to be covered? Because that's all most doctors want. They just want to go to work and take care of their patients. And so when you talk to them about that and say, even if you made a little less money because you're some super mega orthopedic surgeon or whatever now, your freedom is priceless. So that's how I try to get them on board if they are more stuck on financial reasons for not supporting it.
Can I add
I
like
can,
two?
yeah, go ahead.
Two things. One of them, I mean, Victoria, like I was really identifying with you. I have a cousin here who's a lot older than you, who has gone through practically every hospital in the city of New Orleans with, well, fuck it, you can't fire me, I quit. I was looking for a job when I came here anyway, right? I mean, kind of, and the way he talks about the frustrations that he's experienced since med school, right, and all the way through are like quite resonated, like when you were talking. But I guess the other thing I was going to point to, and like this also connects with your initial point, Victoria, that we got to remember that it's not like the world is like carved up into racial groups and to classes in like different categories. There are class dynamics among those racialized populations. And for the last 55 years since the Voting Rights Act, what we've understood to be the political agenda for Black Americans has been set by the professional managerial class, which is the class that's embedded like in the power structures of the Democratic Party, and the investor class, right? Like and so forth and so on. I mean, I remember, going back to like the mid to late 80s when when cultural studies first became a thing in elite colleges. And when I would talk with my colleagues like in FM about material concerns that working Black Americans have, right? I would get a response like, well, but there is more to life than the material concerns. And I always thought, well, yeah, there's more to your life than the material concerns because you belong to the Yale Health Plan and have tenure, right? And like a good job. But what we've watched like over the last half century has been a slow, or maybe not so slow, but a steady accretion, right, of political voice or absorption of Black political voice into a class-skewed discourse that then gets projected out as what all Black Americans are concerned about. I mean, I had the same experience that you've had, like as a surrogate, like in 2016, even in Detroit, right? This came up at a union hall right before the primary. Somebody asked me why Bernie you didn't appeal to Black Americans, right? And we got the question a lot. It came in a basically genuine way from working people. It came in a more tendentious way from people in our class, to be honest, right? And I would say to them, well, all right, yeah, I mean, I hear that a lot. And it's a reasonable question because you hear it a lot. So, and then I just go down the items in a program and say, okay, so in what way would Black and brown people not be the disproportionate beneficiaries of Medicare for all, free public higher ed, $15 an hour minimum wage, right to join a union, so forth and so on. And I know that memory can be reinvented like in self-flattering way, but I swear that I cannot recall one instance when I had that conversation with a working person of color that didn't end with the person saying, oh yeah, I see the point. Yeah, that makes a lot of sense to me. Now it was as likely as not to end when I had it with people in our class in a quite different way because they'd made a prior political commitment and it wasn't and it wasn't like on our side, right? I mean, they're on the other side of neoliberalism. And I think when we start thinking about what talking about racism means and how we do it and what the effect is, I think that's an important distinction for us to keep in mind too as we do it, because ain't everybody on the same side?
All right, well, this has been an advanced seminar on these questions, and I want to thank you both. I know that our movement is so much stronger because you're both so engaged in it. And so I want to thank you for the time, for your analysis, and for really the inspiration that you provided for us today. And it really has been extraordinary. We're going to disseminate this to others in our network. And we hope we can have an ongoing relationship with both of you as we continue to organize and win Medicare for all.
Yeah, I'd love to. Thanks again, Michael.
Thank you, Michael.
Yeah.
Thank you, everyone.
Thank you so much.
All
That was
right.